Hi, everybody. So this week we're going to be talking about the process of accreditation as another example of how organizations can do quality assurance at a systemic level, and then also talking about how to engage communities for program success through a community health needs assessment process. This is the content covered in chapters 9 and 10 in the Curley textbook. I do want to just, I don't know if it's that relevant, but in the newest version of the book, chapter 10 is the header at the top of each page is erroneously labeled the role of accreditation. So it makes it look like there's 2 chapters on the role of accreditation, but it's really only 1. So by the end of today's lecture, you will be able to explain the value of accreditation and voluntary certification as a means of quality assurance, and understand the value of a community health needs assessment and mechanisms for participant engagement in the process. So what is accreditation? Accreditation, like certification, I think we've spoken a little bit during one of our previous lectures about the role of certification. Certification being a mechanism for a nurse, advanced practice nurse, to voluntarily prove that he or she has gained or acquired skills and competencies that merit the award of a certificate. Similarly, at a systems level, typically an organizational level, accreditation is usually a voluntary mechanism to show that there's the intent to deliver evidence-based practice and quality services. It's an indirect measure of the quality of nursing practice because it requires the organization to demonstrate that there has been sort of thoughtful consideration of the organization's readiness to be assessed by an outside entity, and in order to prepare for that, there's a good degree of demonstration of nursing practice that has to be documented and assured as evidence of the quality of care that's being delivered. So in many ways, while accreditation is usually sought after by administrative staff, like hospital administrators, it really is more a function of the nursing staff because it really is a reflection of their practice as opposed to the practice of physicians who may or may not be employed by the hospital, and the administrators who are managing the hospital but not necessarily delivering the care. Organizations that seek accreditation are positively associated with the creation of organizational processes and structures that validate the quality of care that they deliver. So typically, we've talked about this in the past as well, that an organization that has sought accreditation by the Joint Commission or magnet recognition by ACN or other accreditation, for example, as a stroke facility by the American Heart Association, that demonstrates a readiness to be critiqued. And that readiness is a level of transparency that is evidence of, a quality organization. And typically quality organizations, the accreditation process is a public process, and so therefore they're able to, that public demonstration can garner them financial benefits because, patients now that who are well-informed and kind of critical consumers of their own healthcare are able to look up what accreditation the hospital they're seeking care from has sought and attained, and make a decision about who they're going to purchase healthcare services from. and they may be more likely to seek services of a healthcare entity that has sought accreditation. So this is a mechanism to not only bolster the financial solubility of an organization, but also to attract new talent and retain talent, because many times accreditation requires the creation of a team and opportunities for leadership and creativity among the team members. Throughout all of it, there's a prioritization of evidence-based practice. So some of the skills that magnet recognition requires of an APRN, part of this process of getting ready for magnet certification, are an ability to collaborate across disciplines, with multiple members of the interdisciplinary team. The ability for the APRN to advocate for evidence-based practice and demonstrate a full understanding of the way that that can be implemented in their clinical setting. Identification of workflow issues and solutions proposed. So this demonstrates that the APRN is paying attention to opportunities for quality improvement and process and is suggesting or implementing processes to enact those quality improvement processes. There is a great focus on workforce in terms of the APRN's skill set for this, that the APRN is cognizant and aware of and acknowledging their colleagues' satisfaction and suggesting ways to better engage colleagues. They are focused on opportunities for training, because if they are leading a team, they want their team to be all on the same page and prepared for adoption of new techniques or opportunities for change to improve processes. And then the importance of orientation for new staff, so that it's not laborious to bring on new staff, and that the new staff feel like they are prepared to do the job they're being asked to do. So these are all skills kind of inherent in the role of the APRN that are part of the magnet recognition process. And then finally, professional edification, pursuit of a certification, or continuing education and professional development, or assumption of leadership roles. All of these are skills that the magnet organization draws out among participating staff in entities seeking magnet certification or recognition. And then in drawing that out, they cultivate the leadership by focusing attention on the uniqueness of those skills and the leadership potential for members of the team. What are some skills for APRNs in population health then? Whereas that's very specific to the pursuit of magnet recognition, there are some general skills that are identified in the text as essential skills for APRNs who want to practice at the population level. And these include leadership skills, collaboration and relationship building, the need to understand research and understand how to both read research as well as conduct research. And then finally, policy making and development of programming. All of these are essential skills for APRNs practicing in the community. And you can kind of see these reflect the content of this course as we've been talking about it. I think the only piece that's kind of missing from this textbook is leadership. I feel like there's kind of a deficit, but we're going to be covering a little bit more about leadership in the next few weeks in the readings that are not part of the book, as a means to make sure that you're getting this content. So chapter 10 is engaging communities through collaboration, and there's a great focus. I had a hard time just as a reader working through this chapter because I feel like the way it's organized is a little choppy. It kind of jumps from topic to topic. So the way I'm presenting the content is a little bit kind of backwards to forwards, or kind of back of the chapter to front. And I hope that it's not disorienting for you guys. But I think the valuable thing in this chapter, because there's so much that's sort of redundant of other chapters talking about sources of data that could have really been edited out because it's covered in other chapters, and we've kind of exhaustively covered sources of data in the other chapters. I think that the value of this chapter is really in talking about how to effectively engage communities, and it doesn't really even get that deep into effective engagement. So that's why I wanted to sort of drill down a little bit, kind of expose the opportunities for engagement with communities and talking through how community health needs assessments are conducted. The chapter seems to lead with community health needs assessments, and I think that that's really just a mechanism, because a needs assessment is just part of the process. I mean, as we know as nurses, assessment is just the first step. And it's odd to me also that it took until chapter 10 to start talking about needs assessment, given that it is the first step. So, just my personal opinion. The chapter kind of points out that the Quad Council, which is the 4 nursing organizations that direct the core competencies of public health nursing. So that's, just read them out to you so that I don't misstate them. So the Quad Council includes the American Public Health Association Public Health Nursing Section. So within the APHA, the American Public Health Association, the Public Health Nursing Section, the Association of Community Health Nursing Educators, the Alliance of Nurses in Health Environments, and the Association of Public Health Nurses. So, I think I've shared this with you guys before, but the Quad Council, I think at the time that that they developed these core competencies, I think that there was just it was a time when the the American Public Health Association and the Public Health Accreditation Board were coming up with a certification in public health. And so there was a worry that the advanced practice nurse in public community health nursing would be duplicative of that certification. And so they ceased offering the exam for public health nurse accreditation. So certification as a public health nurse disappeared as an advanced practice role or certification. That didn't negate the value of, but it does kind of detract from people's understanding of or recognition of the certification. But it's based upon an understanding that these are the core competencies that public health nurses need to have, and that the former exam and certification validated. Public health nurses have training and skills in assessment and analysis of data. They have policy development and program planning skills. They have skills in communication, development of communication campaigns. They have skills in cultural competency and cultural sensitivity and humility. They have training in community dimensions of practice, in the public health sciences, epidemiology, biostatistics, etc. In financial planning, evaluation, and management, and then in leadership and systems thinking skills. So if this actually, pretty perfectly describes the curriculum of my public health nurse program. And I kind of draw this out because it's an example of how important it is for a nurse practicing in a population, like in the most kind of population health nursing role that there is, shares skills with APRNs functioning in other specialties, but that there is this commonality in certain aspects of the role. To build relationships with communities and to be successful in population health endeavors, the APRNs require skills in leadership, collaboration, research, and policy making. Part of what this leads to is a level of competence and a level of trust that is engendered by that competence. The photo on the right is a picture from a frontier nurse who was, the frontier nurses served in the frontier nursing was established in the 1800s to serve families living in rural areas, and I believe this was taken in Oklahoma or Texas. This is a public health nurse visiting a family out in the West, in the newly settled West. But just thinking of where we started and where we've come in terms of the certification of public health nurses, and the role of the APRN as a population-based nurse, I think you can see that we've come a long way, but in a lot of ways things have stayed the same, that nurse standing there had to have the ability to assess the needs and the assets of communities living in a rural space, had to be able to communicate in a way that was culturally humble, was able to develop programs and promote policies to improve the quality of services available to these families, worked in dynamic environments, likely engaging with rural physicians and policymakers, town leaders, etc. Probably had a good understanding of public health sciences in terms of record keeping and making notes about the children and families that they visited. Probably had to be really good at budgeting and management if she had any assistants who worked with her. And then systems thinking skills, serving as a leader in the community and being able to negotiate, kind of working as a liaison among families and the medical system and public health entities that may have been functioning out there, but also public services or a lack of public services. So while these skills on the left-hand side seem very very complex or sophisticated, I think they're actually rooted in a long history. I also just wanted to point out that assessment is part of the 10 essential services of public health. And while I know that you guys are not necessarily seeking public health specific roles, I think that there is relevance in the that the fact that the hospitals that are 501c3 have to do a community health needs assessment on a regular basis, and that you will be likely through that process collaborating with your local health department or other experts in public health at the state who may be able to provide you with data to validate your needs assessment. This is what public health is based upon, that we function according to these 10 essential services, at the center of which is equity, that equity drives and is part of the implementation of all of these. Assessment, investigation, diagnosis, and addressing hazards and diseases, communication, mobilizing community partnerships, creating policies and promoting laws, using legal and regulatory actions to assure safety and security, enabling equitable access, building a diverse and skilled workforce, improving through evaluation, research, and quality improvement, and finally building and maintaining a strong organizational infrastructure for public health. So around the outside of the public health wheel, you see assessment, policy development, and assurance. These are the three main categories of the work that we do. At the center and pervading everything is equity, but it all starts with assessment. So that's at the top of the wheel. So it's critical to recognize that you can't really get anywhere with a community health needs assessment or any kind of needs assessment without gaining the trust of the community you're working with. And collaboration is a core competency for APRNs, as they outlined in the chapter that the National Organization of, what does it stand for? PNF, the Nurse Practitioners Educators, focuses on leadership and collaboration, that the National Association of Certified Nurse Specialists states that they work jointly with others to optimize clinical outcomes. Throughout all of these APRN specialties, they pointed out nurse anesthetists and midwives as well all have a focus on collaboration, because you can't really get far unless you have the ability to collaborate and work well with others. So community-based participatory research has really become the gold standard in development of needs assessments, and that is entirely reliant upon that the success of a needs assessment is reliant upon the ability to identify willing partners in the community who are able to, guide the needs assessment, and also kind of on a regular basis take the pulse of the community and gauge readiness for uptake of that needs assessment and responsiveness of that needs assessment. I think since the institution of community-based participatory research, there's been just, much better, just in terms of equity, certainly, and respect for communities, and less of a sense of using communities to collect data, but a more successful, what would you say, like a more successful diet of implementation of needs assessments, that once you successfully engage communities and have them lead the way through the assessment, having acquired skills and being adequately recognized and compensated for their participation in the process, that will allow you to really authentically identify goals and build trust, because you as an outsider to that community don't inherently carry trust. And so it's really critical in order to get accurate results. You need to have trust. You can't get trust unless you're engaged with members of the community who already have that trust, or who can build that trust because they're more familiar than an outsider. I would just reiterate the importance of always having end users of your proposed implementation plan as members of the team that are guiding processes. That you can't really say that you're attending to the needs of the population if you haven't had any members of the population involved in developing the intervention. And then how do you actually conduct the needs assessment? These are the sort of steps that you would work through: planning, data collection, analysis of the data that's been collected, setting priorities, getting those priorities validated by the community members, and then sharing the results with the community members, and planning for iterative assessment as needed. Or kind of the other direction that you go from here is initiating implementation of a planning process towards an intervention. So here is the steps. This is a graphic from the American Hospital Association. Step 1, identify and engage stakeholders. Step 2, define the community. So this is setting very clearly the parameters of your needs assessment. Where, who, what's the geographic area? Is there a subpopulation within that population that you're more interested in hearing from because you don't typically hear from them? And collect and analyze data. And this is where the data sources that they enumerate in the text are useful, just to keep in mind that some of the sources of data are the Healthy People 2020 data, your census data, using the community toolbox that we've talked about in the past, the Community Health Assessment Toolkit that's developed by the Association of Community Health Improvement, and the county health rankings and roadmaps. This all will provide you with a certain level of baseline data that's specific enough to describe, most likely down to the county level, a representation of the community's needs and assets. And then the Community Health Navigator, Community Health Improvement Navigator, is a great resource that uses kind of 4 key areas: the who, what, and where of improving community health, collaborative approaches to community health improvement, establishing and maintaining effective collaborations, and finding interventions that are effective. So these tools are kind of presented in a very comprehensive way, and they think they, in the textbook they refer to it as a one-stop shop. It's certainly a great resource, a great tool. Some of the methods for data collection are conducting focus groups, doing key informant interviews, implementing a survey and looking at the survey through a few different lenses, doing windshield surveys or walking surveys where you drive through a community with sort of a checklist of items that you're looking for, or you're writing down observations about the community as you walk or as you drive. Participant observation, so having an opportunity to watch kind of more passively activities that are taking place and sort of observe how they're received, observe participants' level of engagement. It's really an opportunity to sort of voyeuristically, passively observe, so that you can better understand ways that, your observations may inform implementation of data collection in the future. Literature reviews may be helpful, census data, vital stats and state level data may be helpful. And then the CDC's National Center for Health Statistics has just a wealth of publicly available data, and we've already talked in the past about the morbidity and mortality weekly report. But there's so many different surveys that you can access through CDC, from the National Health and Nutrition Examination Survey, the NHANES survey, National Survey of Family Growth. There's data on breastfeeding. There's the PRAMS data, the Pregnancy Risk Assessment Monitoring System. There's so many, sources of data. So sometimes it's not so much a matter of finding more data as refining what you want to look at. Step 4 is selecting priority community health issues. So once you've identified and collected the data and analyzed the data, that's when you really need the engagement of the community to help you select and prioritize issues, because what may seem like a priority to you as a healthcare provider may not be a priority to the members of the community. What may seem like a priority for them may not be actionable to you as a healthcare provider. So it's a matter of coming to mutual understanding about priorities and going into that discussion. That's really where step 1 will benefit you, because if you have identified and engaged with stakeholders, it's less likely that you'll be on different pages when it comes to step 4. In step 5, you're documenting and communicating those results back to the community. So this is where you develop a report, or you create a PowerPoint, or you disseminate a series of infographics through your social media to let everybody who participated know, actually, that survey that you participated in 2 months ago, we actually, found some valuable information from conducting that survey, and we want to share it back with you. What has happened in the past, and I think is kind of a chronic problem with public health and with healthcare providers who deliver direct services through hospitals, is a tendency to assume that communities don't care or don't want to know because they were difficult to engage in the assessment process. And that's a mischaracterization of most communities. I think that there is always interest in data that's been collected from people. It's less likely that researchers take the time to share that data back to community members, and that's where they lose the trust, because there's a perception that you took up my time, you got this data from me, you were getting paid while you were collecting these data, but I wasn't, and now you're not even telling me what the results were, or what you're going to do with the data, or how it's going to change my life. There's a lot of resentment, among community members who are constantly being assessed over and over and over and never seeing the fruits of those assessments. Next is to plan improvement strategies. And again, it's a critical step for the engagement of the community so that you can see what's going to work and what's not going to work. I would insert another kind of step in between 5 and 6, and kind of plan for a readiness assessment to gauge the readiness for change of the community in question, and have the input and feedback of community members in that process. Step 7 is to implement the improvement plans. So whatever intervention you've identified, go ahead and do it. And then step 8 is to evaluate progress, and then go back and determine whether it's time to identify and engage stakeholders again, or is the stakeholder engagement a sharing of the evaluation results? It's most likely that should be the case. So this is sort of a summary of the community health needs assessment process. And again, the value of engaging community members right from the beginning is that you won't end up at the end of this process. You won't end up in step 8 feeling like you didn't actually get actionable data. You didn't actually develop an intervention that would work because you weren't listening well enough, or the information you were getting wasn't from people who truly represented the interests or the needs or the complications of the majority of the members of the community. So that's where some of the pitfalls are, engaging the people who are always engaged, who are just going to give you the same answers to the same questions, either because that's their assumption of what everybody else is feeling, or because they're called upon so often for these kinds of needs assessments, and they're used to giving the answer that the researchers are asking or want to hear. So alternately, there's also the danger of not asking questions in a way that is solicitous, and that's where informed consent and making sure that people who are engaged with the process are helping to craft the questions and convey the questions in a way that's approachable and understandable. So many of these steps are that communication and collaboration, those skills that we've identified as key critical skills of the APRN in terms of collaboration. So that's the last slide for this lecture. I'm going to be assigning a few more readings and a couple of podcasts that I think you guys will find useful. But in terms of the content for the quiz, the quiz that's going to be posted next Saturday and be available for a week for you to take during a 2-hour window of your choosing will cover chapters 7, 8, 9, and 10. Chapter 6 is really content that you'll be covering in the 3rd discussion post, so that's how I'm going to be kind of assessing your familiarity and understanding of that. So the next quiz is really only on the 4 out of the 5 assigned chapters from the textbook, and then you handed in your logic model assignment. You're working on your final presentation, and you have your 3rd discussion post in addition to the quiz. So there's plenty of stuff still to do, but we're kind of getting close to the finish line. And the readings after this point are going to be either listening to a couple of podcasts that are relevant to these topics, and reading a few articles. So that's where I'm going to leave today's lecture. Have a great evening, everybody.